Hello, we are going to talk about nursing care of the persons with personality disorders. After this lecture, you'll be able to identify therapeutic communication techniques for care of the mental health client, discuss differences and manifestations of the selected psychosocial disorders, and identify nursing management, collaborative care, pharmacological management, and non-pharmacological management of these selected disorders. So there are three different clusters of types of personality disorders. So there's cluster A, which is odd thinking and eccentric behavior kind of personality disorders, and that includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. There's cluster B, which is very dramatic and erratic behavior, and this includes antisocial personality, borderline personality, histrionic personality, and narcissistic personality. And then there's cluster C, which is a severe anxiety and fear, and that includes avoidant personality, dependent personality, and obsessive compulsive personality. So starting with cluster A, and these are our odd or eccentric traits, we're going to start with schizoid personality disorder. A person with schizoid personality disorder expressively impassive and interpersonally unengaged. They're not interested in many things. They're unable to experience joy and pleasure in life. They're emotionally cold and distant. They're often introverts. They're reclusive. They like to engage in solitary activities. In fact, they're often lifelong loners. Their interests are more in objects and things and abstractions, and not in having friends or forming relationships or gathering with their peers. Nursing care for persons with schizoid personality disorder, our priorities are dealing with difficulties with social relations and low self-esteem. Often this is going to be trying to help this person engage in like group activities or talking to other people, or maybe trying to form bonds or relationships. A major treatment goal is to enhance the experience of pleasure and to prevent social isolation and increase emotional responsiveness to others. So really we want to teach some social skills, and our primary focus is going to be to increase the patient's ability to feel pleasure, to find something that they enjoy and something that they feel happy about and kind of embrace that. So people with schizoid personalities, they're rarely hospitalized unless they have a comorbid disorder. And because of that, they rarely take medications as well. The kind of opposite of schizoid personality disorder. So the schizoid person is a lifelong loner. They're quiet, they're recluse, they don't make a big fuss, they do not want to be the center of attention. They generally dress normal, they don't want to bring attention to themselves. However, the person with schizotypal personality disorder, this is where we get the opposite kind of personality. These individuals are more dramatically eccentric. They're perceived as strikingly odd or strange. They have unusual mannerisms. They may appear to be unkept or have avoidant behavior patterns. They respond to stress with transient psychotic episodes. So something stressful is happening in their lives, and they kind of have these psychotic breaks and these very unusual kind of behaviors. Many have co-occurring major depressive disorder when they are admitted, and they do end up usually having some period of hospitalization. So pattern of social and interpersonal deficits, cognitive perceptual symptoms, so magical beliefs and perceptual aberrations. So they have these like thoughts like, unicorns and pot of gold at the end of the rainbow and aliens coming down from the sky, and they may see things that are not there. They'll have some referential thinking, remember that term, and that's hidden meaning in other things. For example, a person shopping in a store might see two strangers laughing in a distance, and they'll believe that those people are laughing at them, when in reality, the other two people don't even know that that person is in the store shopping. So it comes with a little bit of a level of paranoia as well. So nursing care is dependent on this degree of decompensation. We want some strategies to increase their self-worth. Social skills training. So we want to make sure that they're able to form relationships and not just kind of be the center of attention, not draw so much negative attention to themselves with these odd and eccentric behaviors. So there's some environmental management there, some cognitive skills, supportive psychotherapy, properly identifying the underlying psychiatric disorder. So there's a picture here with this schizotypal versus schizoid. So schizotypal, they're wearing this purple octopus costume. It's very dramatic and eccentric. It's going to be flashy. It's going to stand out in the crowd. And then there's the schizoid person who's just all in black and quietly sitting, in a corner, not wanting to be seen and kind of blending in, hoping no one bothers them. So those are the key differences between schizoid personality disorder and schizotypal personality disorder, and you really have to be able to differentiate between the two. Both of them need social skills training, but for different reasons. The person with schizoid needs social skills training to learn how to communicate with people, and the person with schizotypal needs to learn how to communicate with people too, but to tone it down. The other disorder in this cluster A, is paranoid disorder. So paranoid disorder is characterized by distrust and suspiciousness towards others based on unfounded beliefs that others want to harm them or exploit them or deceive them. So there's a little mnemonic here about paranoid personality disorder that I think kind of hits this right on the nose. It says, get fact. So grudges are held for long periods. Exploitation is expected without any kind of sufficient basis. Trustworthiness of others is doubted. Fidelity of sexual partners is questioned. Attacks on characters are perceived, like they think people are attacking their character. Confide in others rarely, if at all, and threatening meanings read into events, which means they do some of that referential thinking as well, thinking things mean more than they do. Talking about cluster B personality disorders now, these are the dramatic, emotional, and erratic traits. These are some of our most difficult personality disorders. So starting with borderline personality disorder, someone with a borderline personality disorder truly has difficulty regulating their moods, developing the sense of self with self-identity, maintaining interpersonal relationships, and maintaining a reality-based thinking. So there is a disruption there in the pattern, in a pattern of instability related to self-identity, interpersonal relationships, and affect, combined with marked impulsivity and destructive behavior. So this is often, they set unrealistically high expectations for themselves. And when those expectations are not met, they experience intense shame and self-hate and self-directed anger. They have fear of abandonment, disturbed and unstable relationships often, paranoid ideations, some dissociative symptoms, sometimes suicidal or self-harming behaviors due to impulsivity. And then with their mood instability, some outbursts of anger or feelings of emptiness. They react very emotionally with minimal coping skills, and the intensity of their emotions often even frightens themselves as well as frightens the other people around them. Remissions from acute symptoms are fairly common. They have a low relapse rate. Psychosocial functioning does not necessarily improve, however. So, some safety concerns for someone with borderline personality disorder, they can be extremely volatile and emotionally, so really sensitive. They're high risk for self harm and suicide, and you must take any threats of suicide very seriously. I know we take all suicide threats seriously, but especially with someone with borderline personality disorder and their impulsivity and their heightened emotions, they're more likely to act on those. They have very unpredictable mood swings, passive aggressiveness, and the need to feel like they're in control, um, impulsive binging, risky and aggressive behaviors. The diagnostic criteria for borderline personality, 75% are women and usually have had some kind of sexual abuse in the past. They have problems with identity, self image, thinking, and mood, often using splitting to avoid pain and to protect themselves. And splitting is a very common symptom of borderline personality disorder and is kind of married to that particular mental health challenge. And that's where they can shift very quickly, kind of hot and cold with someone they're talking to. Like if you're the nurse, maybe today they love you and you're the greatest person on earth, and then tomorrow they hate you and you are not their most favorite person and they're talking about you and all of that, splitting behaviors. Biological, environmental, and stress related factors, including a traumatic home environment, abnormalities in their serotonin systems. Suicidal behaviors occur when they're blocked, frustrated, or stressed. So teamwork and collaboration is very important. We need psychotherapy, like talk therapy is very beneficial for these patients. Psychology, social worker, advanced practice nurses are all very helpful. This individual will likely need several types of medications, including mood stabilizers, antidepressants, and anxiolytics. Dialectic behavioral therapy has been researched as the most um, noted to be the most effective in reducing suicidal and non suicidal self injurious behaviors in individuals with borderline personality disorder. Mentalization-based therapy is used to improve patients' capacity to understand others' actions, so trying to get them to be more empathetic. Nursing care, we want to focus on physical health assessment first, unless they're suicidal, and then, of course, if they're suicidal, we do a suicidal risk assessment first. Nutritional assessment, dental assessment, sleep patterns, physical indicators of any self injurious behavior, all medication assessments so we can know if there's any drug interactions, the use of alcohol, over the counter medications, any street drugs, any herbal supplements. Really, we want to know anything that they are taking. You might think that borderline personality disorder sounds a lot like mania, and that is pretty true, but some distinct differences. Borderline personality, this is marked by severe emotional dysregulation with mood swings that last from hours to days. Depression, impulsivity, and unstable personal relationships are very common. Early trauma and brain chemistry are associated with borderline personality disorder. With bipolar, it's a mood disorder characterized by depressive and manic states. Mania can cause excitement and psychosis and elevated confidence. Depressive episodes can cause depression, feelings of guilt, and fatigue. This is kind of an up and down cycle, less so than borderline personality disorder, which is more of the mood swings that happen very quickly. Um, and bipolar disorder is caused by genes and chemical imbalances that are linked to the development of bipolar disorder, whereas borderline personality is more about early trauma and that brain chemistry that's associated with borderline personality disorder. The next one in the cluster B that we're going to talk about is antisocial personality disorder. You may think by the name, and we kind of use this as a loose term all the time, like, oh, that person's so antisocial, like they just don't want to talk to the crowd. It actually means something very different in the world of psychology. A person with antisocial personality disorder, they used to also be called psychopaths, sociopaths, and they do not call them those terms anymore. Now they are lumped under the umbrella of antisocial personality disorder. To be diagnosed with antisocial personality disorder, this would be a persuasive pattern or disregard for and violation of the rights of others occurring since the age of 15. So the diagnosis is actually given to the individual when they turn 18 years or older who fail to follow society's rules. But typically they see this pattern happening at least since the age of 15. They're often referred to as psychopaths or sociopaths. Okay? So the definition, antisocial personality disorder is a mental disorder in which a person consistently shows no regard for right and wrong and ignores the rights and feelings of others. They show no guilt or remorse for their behavior. It is thought that there could be a genetic predisposition for antisocial personality disorder. It also correlates with substance use and dependency problems. It is more common in males, and they tend to rationalize and deny their own behaviors. So the age of onset, they must be at least 18 years old and exhibit one or more childhood behavioral characteristic of conduct disorder before the age of 15. And that includes aggression to people or animals, destruction of property, deceitfulness or theft, or serious violation of rules. The likelihood of developing antisocial personality disorder increases if the onset of this conduct disorder symptoms is seen before the age of 10 and they have childhood ADHD. So often there's comorbidities with this that are associated with mood, anxiety, and other personality disorders. It's strongly associated with alcohol and drug abuse. A diagnosis of antisocial personality disorder is not warranted if the antisocial personality disorder behavior occurs only when in the context of substance abuse. So that means if the person is under the influence of alcohol or another substance and they are exhibiting behaviors of antisocial personality disorder, they will not be diagnosed because it's only occurring under the context of substance abuse. So our first priority is going to be establishing a safe environment for patients and staff. Other mutually agreed upon priorities can then be considered. Outcomes should be short-term and relevant to a specific problem. Group therapy is more beneficial than individual therapy. Types of group therapy are most often used include psychoeducation, psychotherapy, and psychosocial support. Content in group management are structured. For example, they may have two people, like two nurses or a therapist and a nurse, conducting a group to decrease the chance of members sabotaging the message of the therapist. People with antisocial personality disorder are very manipulative, and it's best to talk with them in pairs so you're not by yourself, which is why a group setting is really best for their therapy, and also to have very strict boundaries with them. It's difficult to elicit data due to a mistrust of authority figures. A lot of times they just do not trust authority figures. This is certainly not on the test, but informational slide for discussion only. These are some of famous serial killers diagnosed with antisocial personality disorder and why they were diagnosed. So some of these sound very familiar to you, I would assume. Ted Bundy is one of the most infamous serial killers in American history. He displayed classic signs of antisocial personality disorder, including charm, manipulation, and complete lack of remorse for his actions. John Wayne Gacy, known as the Killer Clown. Gacy was responsible for the deaths of 33 young men in the 1970s. He was diagnosed with antisocial personality disorder and managed to maintain this facade of normalcy while committing these heinous crimes. Jeffrey Dahmer, he was diagnosed with antisocial personality disorder. His actions were marked by extreme brutality, lack of empathy, traits commonly associated with this disorder. Aileen Wuornos, a female serial killer, murdered 7 men in Florida in 1889 and 1890. She was diagnosed with antisocial personality disorder, and her terminus life, marked by abuse and trauma, contributed to her violent behavior. Andres Acapes, known as the Colombian serial killer, was diagnosed with antisocial personality disorder. This diagnosis was based off of his childhood history of abuse, his criminal behavior, and lack of empathy for his victims. That does not mean everyone who has antisocial personality disorder is a serial killer, but it is one of the more intense diagnoses. Important things to remember with that: maintain your boundaries, be mindful of manipulation tactics, do not bend rules for them. Stick to rules very clearly, give directions clearly, and don't deviate. Another one in this cluster is histrionic personality disorder. This is characterized by emotional attention-seeking behavior in which the person needs to be the center of attention, often very seductive and flirtatious in nature. So clients who have dependent and histrionic personality disorders often benefit from assertiveness training and modeling as well as psychotherapy. For clients who have histrionic personality disorder who can be flirtatious, it's important for the nurse to maintain professional boundaries and clear communication at all times. So histrionic personality disorder, what really goes along with this and what I want you to take from this is that this is attention-seeking behavior that is very seductive and flirtatious, and that as a nurse you need to maintain professional boundaries and communications at all times. There is a mnemonic here for histrionic personality disorder: I crave sin, and that's inappropriate behavior, seductive or provocative, needing to be the center of attention. Relationships are often seen closer than they really are. Appearance is of most importance. Vulnerable to others' suggestions. Emotional expression is exaggerated. Shifting emotions. Impressionist manner of speaking, like lacking details, and novelty is craved. The last one in this cluster is narcissistic personality disorder. Narcissistic personality disorder is characterized by arrogance, grandiose views of self-importance, the need for constant admiration, and lack of empathy for others that strains most relationships. They're often very sensitive to criticism. A client who has narcissistic personality disorder can display grandiose thinking, like thinking of themselves as being very important. There are 2 types of narcissism. There's grandiose or overt and vulnerable. So grandiose narcissism is marked by extroversion, they're self-confident, attention-seeking, and they could even be aggressive. Vulnerable narcissism is characterized by an introversion, highly sensitive of negative emotions, negative thoughts, and the need for constant recognition and reassurance. A unifying theme for all forms of narcissistic personality is self-enhancement, the belief that one's thoughts and actions set them apart from everything else. Evidence supports the use of psychoanalytic therapy, CBT, and DBT. Group therapy is also effective for the following reasons. They may have less transference towards their therapist as a group member. As group members reflect on what the patient needs and ask questions about emotions denied by the patient, patients may additionally learn to respect others and develop relationships and empathize with group members. It would not be ideal to be one-on-one with someone with a narcissistic personality disorder. So cluster B, the ones that we just talked about, are very difficult personality disorders. So we have some special psychiatric nursing care considerations here for cluster B. Psychiatric mental health nurses can best help these patients if they use therapeutic communication to reflect emotions that the patient reports and assist the patient to determine what can be controlled. Limit setting and setting boundaries are important tools in the development of therapeutic relationships. When facing challenging situations with individuals with cluster B personalities, use a team approach. Remember that people with cluster B diagnoses usually come from a life history of trauma, rejection, abuse, and neglect, so they're especially sensitive to slights and stigmatization. Recognize that intense dramatic praise and harsh criticism are symptoms of the defense mechanisms of splitting. In both clinical and academic settings, psychiatric nurses can role model identifying stigmatizing language and behaviors and explaining how a personality disorder is uniquely affecting the individual. Significant stigma exists towards individuals with cluster B disorders compared to other mental health disorders, as you can imagine. Cluster C, our last cluster in the personality disorders here, are kind of the less intense personality disorders. So these have anxious or fearful traits, insecurities, and inadequacies. We start with avoidant personality disorder. This is characterized by social inhibition, avoidance of all situations that require interpersonal contact, despite wanting a close relationship due to extreme fear of rejection. So they want to talk to people, but they just avoid all situations because they don't want to be rejected. They don't want to be rejected in relationships. They don't want to be rejected for friendships or jobs or any of that. And so they avoid all of those things. And so they have feelings of inadequacy and they're anxious in social situations. Next is a dependent personality disorder. And so this is characterized by an extreme dependency in a close relationship with an urgent search to find a replacement when that relationship ends. So this could be like a boyfriend-girlfriend situation where either the boyfriend or the girlfriend or significant other or however that relationship is set is very dependent on the other person to the point where they can't function on their own. They lack initiative, responsibility. They're very sensitive to criticism. They have a fear of being alone. They have no opinions. They don't know how to order food for themselves in a restaurant or decide what to watch on TV. Like they cannot come to those opinions without the other person, very dependent on that other person. And then obsessive compulsive personality disorders, and we've already had a lecture on OCD, but it is in fact a personality disorder and it fits into the cluster C. So this is characterized by the indecisiveness and perfectionism with a focus on orderliness and control to the extent that the individual might not be able to accomplish a given task. So we've talked about this before. They have obsessive thoughts and ideas, compulsive behaviors that are used to block those thoughts out. The thinking they want to do something like close the door 10 times, and then the compulsion is actually acting on it. Compulsions can entail overt repetitive actions carried out as time-consuming rituals or more subtle mental routines. Obsessions are defined as persistent and recurrent intrusive thoughts that are perceived as uncontrollable. We will discuss more in class, but that is the end of this PowerPoint presentation for personality disorders and the clusters A, B, and C.